Okay, so if they say to you, hey, the deposition's at 9 o'clock, come in at 8, we'll have some coffee, some breakfast, and we'll give you some pointers. No, no, that is not acceptable. Malpractice attorneys come in all shapes and sizes, and there are great ones and there are not so great ones. So you need to be very well trained for a deposition, and that involves witness coaching, coming to this, going to Toastmasters, getting over your initial anxiety so you can be successful in your deposition. So here's the case presentation. 28-year-old female comes in, says she got the flu, weakness, chills, non-productive cough, chest hurts when she coughs, feels occasionally short of breath, especially when coughing. Got your meds there. Got your vital signs there. Alert and oriented times 3, doesn't appear ill, skin warm and dry, no rash, not diaphoretic, mucous membranes, slightly drier, occasional mouth breathing with nasal congestion. Not looking like a train wreck. Lungs are clear, normal. Exam looks normal. No edema, calf swelling, tenderness. You got normal results. The lab's there. Tell them Dr. Earl said encourage oral fluids, rest, follow up with your primary care physician the next day. Well, obviously it doesn't work out. 2 days later, the patient has a syncopal episode, brought to the ED and cardiac arrest. Cannot be resuscitated. Dies. Massive pulmonary embolus. 8 months later, you get the lawsuit. After several months, we now have the deposition, and that's today. So with that, I will get into character with Dr. Earl here, and we'll have our deposition. At times, I'll turn back to you and kind of get out of the deposition and give you some points. But in the deposition, we play in our parts. So, Dr. Earl, thank you for coming in. I'm Dusty Otwell. I'm the plaintiff's attorney for the poor, family of the patient. Very tragic outcome. Here we are, your attorney's right there. She's going to, keep her mouth shut and object from time to time, but it means absolutely nothing. It might seem confusing, but they're just getting things on the record, and we will continue with the questions. Court reporter's there. She's going to be taking notes the whole time. It's important you speak verbally. Don't say and don't just shake your head. Answer yes or no, because she has to get it on the record. So we'll start. For the court reporter, I'll go ahead and swear you in. Do you swear to tell the truth, whole truth, nothing but the truth?
I do.
Do you understand the penalties of perjury?
I do.
Okay. You understand that if you are not truthful here today, you could be arrested, convicted of perjury?
I do.
You plan to be truthful here with us today?
Yes, sir.
Good. Because that's what this is about. This is about trying to find the truth of what happened to my poor patient. And that's why we're here today, to have a conversation, to get a better understanding of what happened. Should he believe that objective? Yeah. No, I'm here trying to nail him. That's my only objective. And you will see your attacker come in different forms. Where I'm from, in Georgia and the South, they will probably try the catch flies with honey method. That's how I typically do it. Up north and in parts of Texas, they'll be more aggressive and try to trip you off of your game. But no matter how they come, in sheep's clothing or not, remember why they're there. And they're there to try to win the case against you. Have you read anything, reviewed anything to prepare for this deposition today?
I read through a case report that was given to me by my attorney.
Before you came here today, anything we need to know about that might impact your performance? Did you get poor sleep? Are you on drugs? Did you drink?
No.
I was kind of interested in that question here in Vegas, just generally. The reason for that question, anybody guess the reason why they always ask that question, if you're whacked out on drugs or not? Anybody? Well, if later on Dr. Earl says, you know what, I was having a bad day, I was dealing with some medication issues, I had very poor sleep the night before, I had that off the pass with that question. He can't say I was not on my A game that day. So at this point, At this point, we'd go through a long list of your training and education. We'll shorten that. Dr. Earl, where did you go to high school?
Santa Clarita High School, West Ranch.
Okay. And then where'd you go to college?
Chapman University in Orange County.
And then your medical school?
University of Florida.
Okay. I went to Auburn. Yeah, the plaintiff attorney went to Auburn. He's a good one. He's a good guy. Okay, and then where'd you do your residency?
University of Las Vegas.
Okay. In your residency or during your training, did you get any education specific to pulmonary embolism?
Absolutely.
Could you give me a couple of examples of the training on pulmonary embolism?
Can you clarify what you're looking for?
That's a great answer. Sometimes the best answers are yes, no, or I don't know. It is important to know exactly what you are being asked when you are in a deposition. Well, let me put it this way. Are there any textbooks you used or continue to use to assist you in finding something like pulmonary embolism?
Rosen's is the textbook that we generally refer to.
I know Rosen's. Rosen's is a good one. Is Rosen's, is that an authoritative resource on pulmonary embolism?
I believe you could call it that.
Okay. Authoritative is a magic word, and plaintiff's attorneys don't really use it anymore because folks are starting to get savvy to what that means. Because I've pinned you into Rosen's being authoritative, you are held to the standard of Rosen's. And that's what I'm going to start arguing with you about. So in emergency medicine, what would you say, Dr. Earl, is the job of an emergency medicine physician?
I don't understand what you're asking.
Okay, fair enough. Should an emergency medicine physician, with any patient, not just my family's deceased, should he or she rule out the most serious condition first?
So yes.
Okay. Can you do that with the differential diagnosis?
I don't understand what your question is.
Okay. Let me ask, what you've been trained, you had a very good residency in education. So what did they teach you was the differential diagnosis? What is it?
What is a differential diagnosis?
Mm-hmm.
It's a non-exhaustive list of potential diagnoses for a presentation.
Okay. Do you use the differential diagnosis in your current practice?
Yes.
Okay. Did you use it when you treated my client, the deceased?
Yes.
Okay. When you use a differential diagnosis, it's a list of conditions, correct?
Correct.
Do you order them in any way?
Usually you will list them by most severe first.
Okay. So if you've got a list and say, at the top, heart attack, do you rule out that one first?
Depends on your assessment of the risk.
Mm-hmm. Okay. Well, let's talk about risk. Is heart attack a potentially fatal condition?
So, not risk to the patient, but the probability that that is the actual diagnosis that is going on.
If a heart attack is probably going on, like you said, does that present a grave risk to the patient?
Absolutely.
Okay. Now you said earlier that doesn't present a risk to the patient. Did you not?
Sorry, I don't understand.
Okay. A second ago you said to the individual patient, is that a potentially fatal condition? No. But if it's what's possibly going on, we could have the court reporter read it back. But I forgot what you said. In that situation, it'd be great if I had a court reporter, because he said something. You said something about the individual risk to a patient versus, I think you were thinking about the global risk of a heart attack. Maybe you're thinking, most of the time if you're having a heart attack, we can deal with that. Was that in your head?
No,
We're out of character.
my intent was you're ordering your differential and you're ruling things out based on the probability of that's what's going on. So for like any
that
chest
individual?
pain, no, in general, any chest pain could be a heart attack, but in an extremely young, healthy person, it's less likely.
Okay, thanks for that. So, returning into character. So, what about pulmonary embolism? Is that a potentially fatal condition?
Yes.
If a pulmonary embolism was at the top of a differential diagnosis, should you rule it out?
If it's at the top of a differential, yes.
Okay. But it's a potentially fatal condition, and you said potentially fatal condition should probably go at the top of a differential diagnosis, correct?
If they are likely
Yeah.
a cause of the presenting symptoms.
Okay, if likely. So what symptoms are associated with pulmonary embolism?
So you can have shortness of breath.
Mm-hmm.
You can have pleuritic chest pain.
Mm-hmm.
You can have dyspnea, so shortness of breath with exercise.
Okay.
You may have syncope. You may
Okay.
have hemoptysis.
Okay.
You may have evidence of blood clots in your lower extremities.
Okay. Tachycardia?
Potentially.
Okay. So, a few that you listed were shortness of breath, chest pain, tachycardia. Those are consistent symptoms with if somebody has a pulmonary embolism, those symptoms very well might be present.
They may be.
Okay. My client, the deceased, had chest pain, right?
Mm-hmm.
Shortness of breath, correct?
Correct.
Tachycardia?
Correct.
How does a clinician rule out pulmonary embolism?
So there's multiple different tools that can be used to risk stratify and then rule out pulmonary embolism. One is the Wells criteria, one is the PERC score, and for actual diagnostic testing, you can use a D-dimer, a CT angiogram, or a VQ scan.
Okay. Are any of those tests definitive?
No.
And just give me more around that. Say the D-dimer. What does that tell you? What does it tell you if you're looking for pulmonary embolism?
You can use it as part of a risk stratification, as part of Wells score, or in the PERC criteria to give you an idea of the stratified risk of the patient for having a pulmonary embolism.
Mm-hmm. Mm-hmm. Yeah, the PERC score, risk stratification. I understand these are some new advanced concepts in medicine. At the time of the treatment of this patient, who had shortness of breath, chest pain, and tachycardia, you didn't do a CT, did you?
No.
You didn't do a D-dimer?
Nope.
Do you have documentation of the PERC score?
No.
Okay. That is the rule-out game that we try to box you in. That's a traditional deposition tactic. Is it quite obvious what I was trying to do there? Do you see why plaintiffs' attorneys love the differential diagnosis? It's a very sexy argument. I understand the differential diagnosis, and I'm not a clinician. It's just a list, bad things at the top, rule those out, and I'm trying to pin him to pulmonary embolism was possible, but you should have ruled it out, but you didn't. And that's a very typical deposition tactic. Your last answer was possibly one of the best ones. It's just too bad that in the actual case they didn't do any of that stuff. So had you done some of that stuff, we would train you on, okay, this is what they're going to try to do. Now, as a result of that experience, me trying to pin you down to differential diagnosis, and you didn't do the test to rule the things out, just out of character. Anything you would do differently as we're trying to pin you into differential diagnosis? Answers you might give differently? Anything come to mind?
I feel like having prepared answers for some of these questions would be beneficial, because I think the verbiage that I give you, you're very good at turning around and using it to trap me into exactly what I say, even if that's not necessarily what I meant to say.
Yeah.
You have to choose your words very carefully.
Yeah. So, out of character now, how would you describe, if you saw that patient and you didn't do a CT, maybe you did some other things. So how would you describe why didn't I rule out pulmonary embolism?
Based on this case?
Yeah, that's on that presentation. Maybe you did some things differently, but why not do a CT?
I think for this patient, like you said, her Wells score places her as low risk. She can't be perked out. She gets a perk score of 2. But when you look at her primary concerns for pulmonary embolism, it's really the tachycardia and the shortness of breath. You have plausible explanation for the tachycardia because she's taking pseudoephedrine. So that tachycardia may be due just to the medications that she's taking. Shortness of breath, in the constellation of symptoms that she has with weakness, chills, non-productive cough, is more likely to be a viral syndrome than it is to be a pulmonary embolism in a young, healthy female. However, she is on BCPs, so you do have to take that into account. However, in the plan, she was instructed to follow up with her primary care doctor the next day, and in the outcome description, it does not appear that that happened.
Yeah, yeah. Good. And the whole point is, was that reasonable? That the decision-making he just described to me, was it reasonable? And the goal of training you in a deposition would be to find ways to get that across to me, even when I don't want to hear that. But at times, probably in some of the last questions, you'd probably start to get a little pugilistic with me and be like, I don't understand what you mean by that question. And then you would have that prepared spiel and you'd lay it out. And if that was supported by the documentation, I would say, we just had a good deposition, our case just got stronger. So it's about being ready for what I'm going to try to do to you, so you can be ready to do what you're going to try to do to me. But to make it more difficult, we got about 11 more minutes. You hanging in there?
Yeah,
okay, you're doing good. Yeah, that was good. That was real good. So you go into a deposition expecting the rule-out game. Well, there's another game. It's called the reptile rules game. There's a couple of dudes who wrote this book. Plaintiffs' attorneys and defense attorneys are always kind of playing this cat and mouse. So we get tort reform, and they start bumping up life care plans. So we get savvy to the rule-out game, and they start writing this the reptile rules depositions. And the reptile rules, without too much of a spoiler alert, is less about proving a rational argument to a jury, and it's about activating the reptile section of a juror's brain and get them to think something's unsafe here, and that makes them nervous, and they throw money at the problem. So my ideal in the reptile rules deposition is try to make poor Dr. Earl here seem unsafe. So we'll pretend we went through the traditional rule-out game deposition questions, and I'll say, okay, Dr. Earl, we have some additional questions for you. We're almost done. Should a physician needlessly endanger a patient?
No.
Okay. That's a pretty good safety rule. Would you agree?
Depending on your definition of needless.
Okay. What's needless? Would it be needless to hide a danger from a patient?
Yes.
Okay. Give me an example of how it would be dangerous or a problem to hide a danger from a patient.
don't know if I can give you an example of that off the top of my head.
Say you see a danger to a patient. Should you ignore it?
No.
Okay. Why?
Could cause harm to your patient.
Mm-hmm. Cause harm. Mm-hmm. The job of a physician is to first do no harm, correct?
Correct.
Okay. And you have ways to diagnose in order to preserve that rule, correct?
Correct.
Okay. A lot of diagnostic tools at your disposal in a modern ER, correct?
Correct.
Yeah. You can use a number of different tests to diagnose pulmonary embolism. What are some of the tests you might use to diagnose pulmonary embolism?
Well, when they're indicated, you can use risk stratification tools. You can use the D-dimer. You can use CT angiogram of the chest or VQ scans to diagnose a majority of pulmonary embolisms.
Mm-hmm. Mm-hmm. Okay. So the safety and health of a patient who might have pulmonary embolism is largely dependent on a clinician's successful use of those tools, correct?
Correct.
Okay. Is it appropriate to ignore or to misuse the tools at your disposal in the ER?
It is appropriate to choose when they are used.
Okay. Okay. So if a doctor chooses not to use certain tools and it unnecessarily endangers a patient, would you say that doctor is unsafe? Would you like me to rephrase the question?
Please.
Okay. If a doctor knowingly chooses not to use certain tools at his disposal in an ER, knowing that there's risk to the patient if he chooses not to use those tools, is that dangerous?
You fail to consider the danger of using those tools on the patient.
Are you saying that I am failing to consider?
No, but there's risk inherent in testing and there's risk inherent in not testing. And you cannot represent testing as not representing any risk to a patient.
Okay. What is the risk of a D-dimer?
Inappropriate further testing. It's a very non-specific and non-sensitive modality of testing.
What's the risk of pulmonary embolism?
What is the risk? You would need more information to understand.
If a patient, like my client, the deceased, actually has pulmonary embolism, what could happen to that kind of patient?
Well, they could die.
Okay. That could happen to... What happened to my client, the deceased? Could that happen to an athlete?
Could happen to anyone with a pulmonary embolism.
Receptionist?
Yes.
Grandma?
Yes.
Me?
Yes.
Probably wish it would happen to me. Clever plaintiff attorney might say that. Okay. So, would you agree that a doctor should behave at all times in a safe manner?
Yes.
Okay. And he or she should choose diagnostic tools, treatments that are safe.
I would say you should choose diagnostic methods that minimize the risk for your patient.
Okay, yeah. You should choose the option that presents the least risk. Because if there's extra risk, that's a needless danger, correct?
Correct.
That's not prudent, is it?
Again, I think you're representing this as if there's risk only for not testing.
Mm-hmm. What's the risk of CT?
You could have anaphylactic reactions to contrast. You're exposing a young, healthy woman of childbearing age to radiation.
Did you discuss those risks of CT with my client?
It was not documented.
Is it, and you testified earlier, never mind, you said no to that one. Do you wish things had gone differently in this case?
Absolutely.
What do you wish would have been different?
Would have loved to have the patient follow up with their primary care doctor the day after discharge.
As a successful ER physician, where do you get your primary care?
Where do I get my primary care?
Yes.
Share Health.
Share Health. You have good insurance?
I have insurance.
He's objecting like crazy right now. Okay. You have good insurance?
I have insurance.
Okay. Yeah, we all have insurance.
Yeah.
There's no good insurance anymore. You like your primary care physician?
I don't know him that well.
Okay. I have good insurance. Could I get in to see your primary care physician?
I would assume so. If you called him telling him that you were in the emergency department the day before.
When's the last time you went to the ER as a registered patient?
Never.
I understand that most ER physicians, providers, clinicians, even their lawyers, never actually set foot through the front door of an ER. Pretty common. My point being, do you have an idea of how difficult it is to choose to go to the ER, if not get in with a primary care physician, if you're just a random member of the public?
Yes.
You understand those difficulties?
Yes.
Yeah, okay. So considering that, my client was experiencing pain, went through the trouble of coming to the ER, and then, was told to go to her primary care physician. Would you think that it's unsafe for that kind of condition to be undiagnosed in the ER and expect a primary care physician to make that diagnosis?
I think it's fair for that diagnosis to be considered in the emergency department and tested for if it is thought to present enough probability to justify the risk of testing.
All right. Through this case, have you learned anything?
Enroll or not?
Let's step out.
Okay.
What have you learned about a deposition?
You have to be very careful with what you say.
What would you hope our audience learns from your experience here today?
Definitely document very thoroughly on your cases, because this is very hard to defend. Just even your thought process in your MDM, even a couple of sentences to jog your memory as to what you were thinking, what you were doing, why you didn't test. That can all be very helpful when you're sitting here getting examined.
And then the last question, I'll let you go. So what would you think is a reasonable training regimen to get ready for a deposition? What would that look like?
This.
Okay. How much?
I have no idea.
Okay. a couple of sessions?
Yeah, probably.
Videotape it?
Might be good.
Yeah. Luckily, this is being videotaped, so this will save you some money one day if you ever get sued. All right. Well, round of applause for Dr. Earl. Thank you for having the courage to come up here.
Much.
See me a little later. We'll have a little something for you.
Absolutely. Thank you, sir.
Okay. Okay, so we got about 14 minutes, and we'll end this and then have a break at 9:45, correct? Okay, yes. Okay, so just a couple of closing comments. So I hope you all got exactly what we wanted you to get from the mock deposition. Of course, Dr. Earl slipped up on a few things. If I went and played for the Atlanta Braves right now, I would fail because it's a weird experience, something I don't do, and you have to be well trained for it. If I stood up here and tried to do this without preparing at all, that would go a lot worse than it's going. So in those strange situations, those of you who have been through mediation, deposition, you have to be well trained. You have to be engaged in the process and say to your attorney, I'm not really feeling it. I need to get a bit more training so I can be successful. In the end, though, what he did at the end of the first set of questions was really what you're trying to get trained to do. You're trying to be trained to make your point and defend against the point they're trying to make. So finally, we're back in our malpractice case, and that's how we're going to close. You've been sued. You've done what it takes to cope with the litigation. You've been through discovery. You've reviewed the records. You've been through your deposition. Trial is not far away. And we have to have a conversation with you about whether or not you should settle. Even in strong cases, we have to have that conversation. And sometimes clinicians can get frustrated with that conversation. They say, I feel good about my case. I'm going to trial. Why are you talking to me about settlement? Well, it's like informed consent. If there's a low risk of dying, you still need to tell them about it. So if there's a risk you're going to lose your trial, we need to tell you about it. And if there's a settlement offer, we're actually legally obligated to tell you about it. Even if they say $25 million, we have to tell you, and we have to walk you through the pros and cons of it, even if it's a no-brainer that we don't take it. So we have to tell you about whether or not you're going to settle. So if you're making that decision, and if you are in malpractice litigation, there's a very strong likelihood you're going to have to walk through that decision of settling or not. You go through pros and cons. Now, there's a lot of solid benefits of settlement. Again, it is a certainty. When you sign those settlement papers, it is over. And you don't have the risk of trial. Now, even when, we think we have a really good chance at trial, we're throwing numbers around, 80%, 90%. I mean, it's very, very hard to estimate what 12 jurors are going to do in a complicated medical case and what they're going to decide. Also in a settlement, you would be surprised at the language in the settlement document. It is very vanilla, and there's no admission of liability. It just kind of says, this happened, this money is being paid, and we're going our separate ways. It doesn't say, Dr. So-and-so is a horrible clinician. It doesn't say the APP screwed up. It says there's no admission of liability, this is confidential, this money's being paid, and we're going our separate ways. So there's a lot of nice benefits and certainty and risk mitigation of settlement. But you don't get your day in court. You don't get that catharsis of really trying to convince a judge and a jury that you were right. And in a settlement, you are going to have a data bank report. It's very hard to prevent a data bank report when we're paying money on behalf of a clinician. And we'll get into what that means for your career here in a second. Now, there are pros of going to court. You get your day in court. And if you win, there's no negligence, no liability, there's no data bank report. You look great. If you win. And you have to sit there for a long time to win. I mean, just think about it. Sometimes trials are weeks long. But if it's a short trial, it's 2 weeks, you need to be there every day. Can you imagine scheduling that out? It's grueling. It stinks. It drives you crazy. All the attorneys, they're having a great time. This is what we do. They love it. And you are having a very hard time. Everything is at risk. So when you just have these people, there's just these risks you can't adequately estimate. And if you lose, and I have lost a trial before, that's a pretty bad data bank report. Verdict for the plaintiff. And even if we say, you know what, we just don't see a possibility of liability over $1 million. Let's say your policy limit of your insurance is $1 million. There's just no way this guy's not hurt that bad. Maybe we even have a tort reform state, and it's capped at $250,000 plus maybe $250,000 of actuals. Risk is $500,000. A jury can do whatever they want to do. Now, it can be appealed and struck down and limited, but still, that is a very anxious place to be if you get an excess verdict against you, and I say, oh, don't worry, we can get this appealed, we can get this knocked down, but you're going to be in a very uncomfortable position, and that's possible when you look at a jury. They can really do whatever they want to do within some limits. So when you're making that decision, what am I going to do? I'm going to settle. I'm going to go to trial. I feel pretty good about it. Well, how's this going to affect my career? That's what you're worried about with a data bank report. You're worried about credentialing. You're worried about future jobs. You're worried about your future prospects if you have a data bank report. I think data bank reports generally are considered by clinicians to be more important than they really are, but they do have an impact. And it just depends on how big and how many. So if you have a 5-figure case, if somebody is willing to let your case go for under 6 figures, and that seems to be a successful resolution, that's going to have little to no impact on your career. If I see a $75,000 settlement that comes across my desk, actually, they don't even send those to me because they know the credentialing department, the people who are hiring folks, that is a nuisance settlement. That is, maybe there was some slight problems in this case. It was cheaper. We had an opportunity to just pay him $50,000 and save the clinician 3 years of hell. Getting into 6 figures, maybe there's some questions. I have never seen a clinician lose out on a job because of 6-figure settlement, but there's some questions. And the best thing to do is just answer them proactively. Have a letter ready to go from your attorney, a letter from you. Here's what happened, and here's what I've done to improve my practice if necessary. Maybe the state board looks at you as well. Maybe they catch wind of the settlement, and then you get kicked while you're down. You just settled the case, and now the medical board's looking at you, and that stinks. But even at $1 million, I mean, I think employers, credentialing departments know what $1 million means in a malpractice suit. It means there's a possibility of risk there. But think about the case with the baby with the amputations. And that's $1 million case. You think that physician should not be hired? No. The physician should have to answer questions and say, here's why we did the right thing. It was just, look at the damages. So, it depends. And if it's a small amount, you're really not going to have a lot of problems later on. Now, frequency, kind of the same thing. If you got a case or two, we're probably not going to really look at you. But if you've got a lot of cases, actually what that tells me is you might be pissing people off. A lot of times the difference between somebody with appendicitis who just says, oh, this stunk, or they sue the provider is their image of the provider. If they thought the provider was rude, blew them off, I have seen those kinds of attitudes bring lots of suits, and little piddly ones that just drive you crazy. So it just kind of depends on how many you have. So when you're trying to make that tough decision, should I settle or should I take myself to court, just think about. So some wisdom I've heard from Texas is, don't wrestle with a pig. You're going to get dirty, they're going to get dirty, but they're the only ones liking it. And that's true. Lawyers, judges, this is what I do for a living, and I love it. I love the law. I love going to trial. I love trying to prove my client's case. But I may be having a good time, but they are not. And there's a lot of risk involved there. So I am totally cool with them saying, you know what? It's not worth it to me anymore. Let's take the deal. And that's very reasonable. With that, I'll have time for one question, and then we're going to take a break. Anybody have one question for me for the good of the order, and then I'll be available during the break? Yeah.
How much should you trust your lawyer's judgment on whether this should be settled or not? Because my
Yeah.
was always, you may not know about,
Yeah.
I don't know enough to tell you, yes, we should
Mm-hmm.
go on, or yes, we should go to trial.
Yeah. That's a great question. And the question is, we hire these lawyers to defend you. And where are you from? Okay, Texas. Yeah. I know a lot of Texas lawyers are very good. That we hire these lawyers to defend you, and they say you should settle or defend, or here's your risk. Should you trust them? Why should you trust them? Great point. There's a wide variety of talent among lawyers. Different insurance companies use different lawyers. And some of them are very good at making that prediction, and some of them not so much. And there's kind of two classes of attorneys and insurance companies in how they make that prediction. And it's kind of like physicians. You got some of the old school ones who are just like, well, I know Bob, and I know that judge, and I know what's going to fly in Bexar County. And they kind of, take it from the gut. And then you've got kind of the new school who uses a lot of data. They use even AI in old cases to predict how it's going to go and then the possibility of the verdict. You might not be surprised, I'm more in the data camp. So I think you really need both. You need the fellow on the ground who just knows the judge, knows the plaintiff attorney, and can add color to the data. And the data being, because of this case and this case, and a verdict search. Verdict search is a very important term you want to hear about. Because of the verdict search, we're seeing about a 75% chance, and we're seeing a verdict range of this much to this much. And you push on those numbers. I think a thing about lawyers, it maybe in contrast to doctors, is if you don't challenge us, we will just keep talking. So I think as physicians, you are trained, you've got to give them all the information so that they can make an informed decision. But some lawyers, if you let them, will just kind of run over you because they think it should be settled or they think it should be defended. But in those instances, ask questions. And a good term to remember would be verdict search. What did you find in the verdict search? And if they haven't done one, that'll kind of challenge them to really dig into the data to give you a better explanation of why you should settle or not.